Helen Pears. I am a consultant in general adult psychiatry in Liverpool, and I've been a consultant here for about 14 years. I'm going to speak today on working with people who are seeking asylum and with refugees, and in particular with focus on their mental health. So I shall just try and get my slides to share.
Just while you're getting your slides up, I'll just read out your bio that we've got for you here, so everyone knows just a little bit about you as well. So Helen is a consultant general adult psychiatrist and clinical subdean for psychiatry at the University of Liverpool and Edge Hill University. She attended the University of Liverpool Medical School and completed her postgraduate training in Merseyside. She's worked as a consultant for 14 years in inner city Liverpool, mainly community mental health teams and inpatient settings, before moving to her current post as an adult ADHD consultant in Sefton. Helen developed a special interest in the mental health of people seeking asylum and refugees, whilst working in a CMHT in Liverpool that is home to several initial accommodation centres. She attends the Liverpool Asylum and Refugee Health Network, latterly the Council's Our Liverpool Asylum Strategy meetings, where she's developed her knowledge of the regional offer of mental health care of this group and has been part of developing a number of other local resources. She's currently co-authoring a book chapter on developing mental health services for people seeking asylum and refugees.
Thanks. So this talk I've done before previously. So I just wanted to mention Mohammed Taher, who's put together these slides with me in the past. He's not speaking with me today, but he's very good at speaking about these issues if you ever do get an opportunity to hear him in one of his presentations. So as I say, I'm a general adult psychiatrist, and I became interested in this area through my work mainly. And so the session I've put together today really is to raise awareness around issues of health, and particularly mental health care for people who are seeking asylum and refugees. Also to give an overview of some of the processes that people who are seeking asylum in the UK have to go through and some of the difficulties with those. I'd like to give a short overview of some of the mental health conditions that are common in this group, particularly complex post-traumatic stress disorder. And then at the end, there is an index really of support services within the region and nationally, which I'll quickly go through, but which you can always request copies of the slides if you wish to keep those details. A lot of the provision in Liverpool is third sector, so there's quite a few organisations I'll mention there. So as I said, I became interested in this area because of my work, but actually I've been interested in issues of equality and diversity in healthcare and in general for many years. Mainly really since my teens, when I was on my way back from a football match at Bescott, the home of Walsall FC, with my boyfriend at the time, who was British Indian, and with his friend, also British Indian, and my little brother, who would have been about 8. And unfortunately, we, on the way back, were set upon by a group of neo-Nazis, I suppose what I would call them, skinheads, the racists, and they beat us up. They didn't beat me up particularly badly, but my boyfriend and his friend unfortunately were quite badly injured. And two things that struck me in the aftermath of that were, first of all, just the complete prejudice that these people had for my boyfriend, who I knew to be a fantastic person. Also, that how much the kindness of strangers helped him afterwards to recover. Many people immediately while it was happening stopped their cars. One man suggested that he would run after these guys and try and stop them, and they were really big guys. It was very brave of him. Neighbours were coming out and helping, and really I was struck by how important it was that those people did that and showed solidarity with his plight at the time. And clearly what happened is, very minor compared to the things that have happened to many of the people arriving on our shores seeking asylum. But it's sparked in me an interest in racism and prejudice in our society. When I became a consultant in psychiatry, I worked in a Rundle patch, which is a community mental health team covering central Liverpool, mainly Kensington, Toxteth, Edge Hill, and happens to be one of the largest dispersal areas for people coming to the UK seeking asylum. Many of them, after coming through the big hub airports like Heathrow, come straight to Liverpool, to the various accommodations that are listed there, like Burley Court. And so I was noticing that many of my patients who were being referred were people who had been seeking asylum and had mental health issues. And thirdly, the other thing that sparked an interest was through that, I ended up going to what used to be called Meringue, is now called Refugee Women Connect. And it was probably one of the most welcoming places I've ever been. It is a project run for people who, refugee women, and run involving the refugee women in the running of the groups there. There are postnatal groups, various groups. I went along to one, and it was a mothers and babies group. There were women from all over the world talking to each other, trying to talk to each other, people spending their free time voluntarily running this group, people bringing in clothes and supplies for these women, many of whom had nothing. And it really got me interested in the types of communities that people seeking asylum were beginning to put together in the UK. And this was a small example of one of them. So as we know, the media's view of people seeking asylum can be somewhat misleading. You see here some headlines that we won't be unfamiliar with seeing, calling Britain the asylum seeker capital of Europe, people complaining about bogus refugees, talking about how we can't take any more migrants to our shores, suggesting that people who seek asylum are being put up in 4-star hotels. And so obviously these go on and on and on. Here they all are. In fact, the reality is quite different, and I'll go on to explain some more about that. Just starting, however, with some definitions. So an asylum seeker is a person who has applied for asylum under the 1951 Refugee Convention on the Status of Refugees. So they apply on the grounds that if returned to their country of origin, they would have a well-founded fear of persecution on account of race, religion, nationality, political belief, or membership of a particular social group. Once actually accepted to stay in the UK, often for a limited initial period, that's when they become a refugee by nomenclature. But obviously, aside from that, these are just people who have been in the wrong place at the wrong time. We've all seen this year how unexpected events can lead to massive changes in societies very quickly, how people can come to power that perhaps we never thought would, and how people's lives can change very quickly. So aside from the headlines, obviously these are mothers, daughters, sons, fathers, various different professions. Some people arriving will have very little education. Many of them will have a lot and be very highly educated. Some may have come from poor backgrounds. Many of them don't, and may have had a good quality of life in the UK, and so in their country of origin financially. And they come to a system that is fairly impoverished. The stresses for people seeking asylum are many and varied, and I'll only touch on a few of them. Pre-migration, clearly they are what I've already mentioned: war, persecution, possibly torture, imprisonment, loss of family members, bereavement. The list goes on and on. During migration, many people will have spent most of their money or all of their money to make the trip to the country they're trying to reach. Often that will have been involving trafficking or some illegal way of entering the country, which means it's completely unregulated, and many people have very many traumatic experiences, which we've all heard about in the news, on their journey to a safe place. Often people lose track of family during their migration, and their migration may take months or years. Unfortunately, post-migration, things don't necessarily get better straight away or at all, unfortunately, in some cases. And I think that's mainly really to do with the systems in which people find themselves once they arrive in the country that they've sought asylum in. And all of those obviously increase the risk of mental health problems. So here we see some people obviously on their journeys. These are the pictures we've seen in the news, of course, the centre in Calais, various refugee camps. Once they come to the UK, they enter the asylum process, which is briefly outlined here, but can take several years. So making an initial application for asylum, they will have a screening interview and an asylum interview. Now, that process can take a very long time. And during that time, you'll see in the next slide, they're likely to have moved around the country numerous times. They then get eventually a decision from the Home Office as to whether they can stay in the UK. If that decision, which only 30% or so of the time is that they can stay, they may be granted refugee status, which will usually be for a period of time, for example, up to 5 years, in which case it would then have to be reviewed after 5 years. They may be granted status on humanitarian grounds or have discretionary leave. It's a complex, there are complex varieties of combinations of periods of time that you can stay and reasons to stay, many of which are quite anxiety-provoking in themselves because they do have to be reviewed again. So people are often left in a situation then where they can stay, but they're not sure how long they can stay. More often, however, their application will be refused. And then they have the option of an appeal, for which they will, of course, need a solicitor and funds, which are hard to come by. If their appeal is successful, again, the same types of status apply. If it is again refused, they may be able to make a fresh claim if there is further information that could be added to their original claim, or have a further appeal to the upper tribunal. And if all of those avenues fail, then their options are either removal or voluntary return to their country of origin. During that process, as I've mentioned, they will move accommodation a number of times. So many times people won't be able to speak the language. They may not know the geography of the country, but they tend to come in through the big UK airports. We moved initially to the induction centre of the UK Border Agency, which is a large centre. And then fairly quickly are dispersed to 5 main centres. This is slightly out of date, I think, this slide. There's possibly slightly more now, but London, Liverpool, Glasgow, Northern Ireland, I think, is Belfast, and Birmingham. And there they are put into accommodation centres, which are provided by various private providers. And in the Northwest, that's Serco at the moment, as far as I'm aware. They should be there only for about 2 weeks, but actually they're often there quite a lot longer. And during that time, they have a kind of a screening process where they are seen by a GP at Urgent Care 24 in Liverpool, and their health is fully screened. They're screened for whether they've had vaccinations, screened for all sorts of physical health conditions, also mental health conditions. They have input from Migrant Help, which is an organisation that assists people with understanding the system that they've entered. And in Liverpool, they are also seen by the social inclusion team, one of whose main aims is to help people to register with a UK GP so that they can then access the health system. They've been remaining in this accommodation much longer recently because of COVID. And these are generally poor quality, unfortunately, accommodations. One of the ones I think used to be many years previously, a student accommodation that student has long since moved out of. And certainly when I visited there, there were, one family in a whole family in one room, not necessarily in the greatest state of repair, shared kitchen and bathroom and so forth. And often the people are very frightened. They're mixed in with people from other countries whose languages they don't understand, or even people from their own country who perhaps were on the other side of the conflict that they've been fleeing. There are many, many stresses on people whilst they're in these accommodation settings. They're then moved again to what's called dispersed accommodation throughout the city. So in Liverpool, these are throughout the city, often in areas of fairly high social deprivation, fairly cheap accommodation, again tending to be maybe flats where there are other people seeking asylum in the same building. I've found that people's accommodation hasn't been, again, of very good standard. Their accommodation may come to be known as somewhere that people seeking asylum are accommodated, and they may find themselves being targeted there, unfortunately. And people often wait there then until their decision from the Home Office, which can be many years, as I've mentioned. The Northwest, in fact, houses a huge number of people seeking asylum as compared to many areas of the country, 16 times the number housed in the Southeast. And given that Northwest has some of the most deprived boroughs in the country, it illustrates, I think, the types of housing, unfortunately, that people are finding themselves in. If they're granted asylum, then they must move again. They're usually offered accommodation by the council in the area that they live, and they're offered one attempt, really, at getting accommodation. If they don't take it, then they risk not being offered any more and becoming homeless. And they have 28 days after getting their refugee status to get a biometric card from the Home Office, sort out a national insurance number, get some benefits, to register for those, whichever ones they might be eligible for, and also to find accommodation and move. Otherwise, after 28 days, their Home Office funding and their accommodation ends, and they're essentially on their own. So just a few facts. The vast majority of refugees actually stay in their region of displacement, and so 86% of the world's refugees are hosted by developing countries, Turkey hosting the highest number of refugees at over 2 million. The UK is home to only 1% of the world's refugees, and as of 2019, the population in the UK of people who are refugees or have pending asylum cases made up just 0.6% of the UK population. In fact, Germany granted asylum to more people than any other EU country by quite a long way in 2019. And in the UK, we rank 15th amongst the EU, as we were in the EU, 28 countries. The top five most common countries of origin of people seeking asylum were Iran, Albania, Iraq, Pakistan, and Afghanistan in 2019. In contrast, those granted refugee status, that should say, not statues, between 2010 and 2020, the most common countries of nationality for people getting status was Syria by quite a long way, followed by Somalia, Iraq, the Democratic Republic of Congo, Sudan, Ethiopia, Bhutan, Eritrea, and Afghanistan. And those change quite frequently depending on what's happening in the world. The regions with the largest number of people in dispersed accommodation per 1,000 resident population in this last year was the Northeast, followed fairly quickly by the Northwest. As I said earlier, 34% of asylum applications, this is between 2016 and 2018, are granted protection at initial decision, and 54% at appeal. So of the people arriving in the UK, half won't be allowed to stay in the UK. And that actually is going, that the time that it takes for people, to receive a decision is getting longer and longer. So in 2014, 87% of people applying would have a decision made within 6 months. Whereas in 2019, that had reduced to 20%, and I believe has reduced further with COVID. So a lot of people are waiting a very long time, unfortunately, then to find out that they cannot stay. Just some interesting information about refugee doctors. As I say, many of the people coming to the UK are very well qualified in their country of origin, and 1,200 medically qualified refugees are recorded on the BMA database. I don't have a date for that statistic, unfortunately. It costs around £25,000 to support a refugee doctor to practice in the UK, whereas training a new doctor costs an estimate between 200,000 and 250,000. So people, once they arrive, unfortunately aren't allowed to work, and therefore we have large numbers of very well qualified people, unfortunately unable to use their skills. I haven't put in there, but whilst they aren't allowed to work in the UK, they are able to access a small amount of money per week, which I think is about £39 per person per week at present. And so that's for all their costs over and above accommodation. Often people seeking asylum have to travel quite a lot. They have to travel to the Home Office, which may not be the Home Office in the city that they're located in, to present themselves for various interviews. They may have relatives in the UK, but in other parts of the UK. And obviously, in any circumstances, £39 a week doesn't go very far. All people seeking asylum and refugees in the UK are entitled to register with a GP. Sometimes there's some confusion about that, but they are eligible to receive free NHS hospital treatment. GP practices can retain the discretion to refuse to register refused asylum seekers as well. Treatment of certain communicable diseases such as TB and compulsory mental health treatment, and all treatment provided in A&E is exempt from charges for all patients. And this is from the BMA. Health professionals should not discriminate against people seeking asylum or refused asylum seekers by unfairly prioritising other patients in preference to them. People who have been refused asylum often will end up staying in the UK for one reason or another. And in England, refused asylum seekers and people seeking asylum who aren't receiving benefits might still be entitled to free prescriptions. So it's actually quite complicated understanding what people are and aren't entitled to, but actually a simple rule of thumb is most of the time they are entitled to most things. So the stories that hear about people being sent away from A&E departments shouldn't be happening. Most people seeking asylum are entitled to use the NHS whilst they're here. Key as well to that is that it's not the responsibility of doctors to make the decision about the eligibility of patients for free NHS hospital care. So that is down to the government, and therefore I think a good rule of thumb is to treat people when they need the treatment. If, for example, somebody was undergoing a course of hospital treatment, at the time their claim for asylum was rejected, they are entitled to continue with that treatment until it's completed. So going on to health conditions in people who are seeking asylum, of course, they're the same as for any of us, but with certain additional issues. Often their health is worse for so many different reasons, but including health being neglected due to periods of imprisonment, torture, or perhaps due to rape prior to migration, which might leave them with injuries. They may not have had good healthcare provision in the country of origin. Their journey to the UK has likely been difficult and may have impacted on their health. They likely have become isolated during that journey and lost the support of friends and family, lost their status, lost their home and so forth. Also a lot of kind of mental health stressors, uncertainty about their asylum status, culture shock, and unfortunately racism in the UK can all contribute to their health. Once arriving in the UK and trying to access health care, there are various barriers, language barriers, difficulties in communicating across different cultures, particularly in mental health, in understanding each other's conceptualization of mental health, what mental illness is and what it means for a person, their status and their family. They may have difficulty accessing healthcare services, as I've alluded to before, in terms of registering with GPs, being accepted for treatment free of charge. They may not be aware that they're entitled to treatment and therefore may leave health conditions without treatment for quite a long time before becoming aware that they are actually eligible to have their condition treated. There's various tips then for working with people seeking asylum. So keeping all of that in mind, often people, as you'd imagine, arrive in the UK frightened, very frightened of the system, very frightened of authority, very frightened of who doctors are, who they're affiliated to. So I think when working with someone who's in front of you seeking healthcare, it's important to set the scene for them and to assure them that actually the NHS in the UK isn't affiliated with the Home Office. It's not affiliated with the police. We're not going to charge them as they leave A&E. And obviously to explain to them the boundaries of confidentiality, and that there are some situations in which confidentiality would be broken, of situations of high risk, but that in general, what they tell us isn't going to be reported to other government bodies and is going to remain confidential within their records. And that can make a huge difference to someone who really hasn't a clue how the system works here when they first arrive. I'm speaking to lots of people seeking asylum and seeking their views. It's key, I think, to be friendly and welcoming to people. Many people say the thing that helped most was being offered a cup of tea, being offered somewhere for their children to sit, somebody perhaps playing with their children so that they could speak openly whilst their children are occupied, because of course they're unlikely to have any childcare when they first arrive, and they may not just want to speak about their experiences directly in front of their children. I think being aware of our own biases is always important in every circumstance, but being aware of the things that we might think we know about the country that the person has come from, the things we might think we know about what their life was like before they entered the UK may well be quite wrong. It's difficult in the UK system, certainly in mental health, I think, to avoid asking people to repeat their story, and they often do have to do so, but where possible, trying to make sure that you've accessed the notes, read the previous records, and preventing yourself from having to ask people to tell you all over again the things that have happened to them. Really just keeping in mind not re-traumatizing them, and also keeping in mind the shame and the fear they may feel about talking about things that have happened to them. Working with interpreters is key. There are various basic things to keep in mind when working with interpreters, making sure you can see the interpreter and the patient at the same time, making sure that the patient can see both of you, but also considering how to select an interpreter. Gender may be important for some people if they're going to be discussing issues of sexual violence, for example. The background of the interpreter may be important. They may speak the same language, but could be from different ethnic groups in the country of origin, which could be very significant for the person you're speaking to. Fears about confidentiality can be a big thing. Often there are small communities, particularly in a small city like Liverpool, for example. We have quite a few Eritrean refugees, and there are small communities. So fears about somebody from that community who speaks their language, knowing about their personal information and possibly knowing somebody else in the community, and not maintaining confidentiality with that information. There's issues, all sorts of issues. Sitting in the waiting room together, interpreters often will try and strike up conversations. That can be quite awkward for people who are already feeling fearful. Sometimes it's very helpful, but keeping in mind, perhaps asking the person whether they want to sit with the interpreter beforehand. Also, I think having a conversation with the interpreter beforehand about translating everything that's said rather than trying to summarize what's been said. It's important, particularly in mental health, because the way that things are said is important in trying to understand their symptoms. Checking understanding with the person who you're speaking to, obviously, is always important. And I think considering the whole person, and not just their health situation, but also their family situation. If they're unwell, if they've had an injury, do they have somebody to go back to who can support them? Do they have someone that will help them to the toilet? Do they have someone who can, for example, feed them if they're very depressed? Or somebody, if they're very anxious, who can go and get food for them? All of these things very difficult for many people having first arrived. Do they have any social connections? Do they have a sense of purpose and an idea of where they want things to go, how they'd like to use their skills in this country in the future? All those things are so important, I think, for all of our mental health. Issues of finance may be something that needs considering. Can they get together the bus fare to get to the X-ray department that they need their tests doing at? And then other things just about their general life. If their children have come with them, do their children have a school place? Do they know how to get a school place? Are they able to speak enough English to navigate the system of getting school places? Are any of their children at university, or were they at university? Were they in the middle of studies? Would they want to restart them at some point? All of these things, I think, are really important to trying to understand where a person's coming from. It's important to be aware of beliefs about mental illness in other cultures, and I think Dr. Wilkinson will talk about that afterwards, but beliefs about mental illness can be very different, obviously, between in different countries. I think it's important to talk to people about the fact that in the UK, mental illness is seen as, well, mostly seen as an illness, that there is still some stigma, but that in general treatment falls under healthcare services. And then last of all, keeping in mind that there may be minorities within minorities. So you may be seeing somebody who's come from their country of origin for various reasons. And one of their reasons might be that they are in a minority that is persecuted, for example, because of their sexuality, or they may be transgender, and they've come here seeking safety, and actually may need some support with that, as well as whatever else they might have come with, whether they might have come with depression, anxiety, or whatever. And there are some services in Liverpool, certainly, that are very helpful in managing support for people who have issues of persecution because of their sexuality. Some bits of information here about physical health. So there are poor antenatal care and pregnancy outcomes, unfortunately, amongst women seeking asylum and refugees. They often haven't had good antenatal care prior to coming to the UK. Perhaps during their journey they've become pregnant, and they're very much more likely to develop complications during childbirth, and three times more likely to die during childbirth. Therefore, linking pregnant women and recently postnatal women in with the right healthcare is really important. There are other concerns, obviously, possibly related to that, but female genital mutilation, domestic violence, sexual assaults may need to be particular sensitivity to those factors. And disability, one of the things that I think is important to consider with the patient is, what does disability mean to them in their culture, and what does it mean here? And do they have dual needs, both as a person seeking asylum and somebody who has a disability that need attention? I mentioned before, so I won't go into this very much, but there is immunisation programme on arrival at the UK. So if immunisations haven't been covered in their country of origin, those can be given in the UK. There is usually some sexual health surveillance and HIV testing, and there is surveillance for chronic disease such as hypertension, diabetes, which may not have been diagnosed in the country of origin, either because the healthcare service there was suboptimal, or maybe because their journey here took so long that they've developed these conditions along the way. There is also often reported dental disorders, which can cause considerable distress. In mental health, just for the last few minutes, depression and anxiety, as you'd imagine, are common. PTSD is greatly underestimated, even in this group, and often contested by healthcare professionals and by the Home Office. And I think that's because it's not well understood, because often in this group, the post-traumatic stress disorder is complex. Post-traumatic stress disorder in ICD-10, International Classification of Diseases, is categorized by having had exposure to a very exceptionally threatening or catastrophic stressful event, and then being plagued by persistent remembering or reliving of that stressor, so nightmares, flashbacks, etc., and actual or preferred avoidance of triggers for that reliving. Alongside that, they would usually have either an inability to recall some important aspects of the period of exposure to the stressor. So you can imagine in the Home Office setting, that could be quite relevant, as they are required to recall what has happened to them. And that might be extremely difficult, if not impossible, for them to do, and can lead to people not being believed. Alongside that, they may have persistent symptoms of psychological sensitivity and arousal, for example, difficulty falling asleep, irritability or outbursts of anger, difficulty concentrating, hypervigilance, looking around for threat, and exaggerated startle response. And all of these make for a disorder that's actually very difficult to prove for them, and which can become even more traumatic. And they will often have to recall and recall and recall their story, possibly sometimes making slight errors in their recall, all of which unfortunately can mean that it's difficult for them to build a case for the Home Office that's believed. In complex PTSD, there are additional symptoms, and pretty much everyone that I've seen as a general adult psychiatrist who's seeking asylum had complex PTSD, because their trauma had been compounded in so many different ways. And it can take very many weeks or months to develop. Often people, alongside the other symptoms, develop a feeling of separation and a general lack of trust, as you might imagine, alongside feelings of shame and guilt, and also a sense of numbness, which can mean it's very difficult for them to express themselves at all, or to show their feelings, again, contributing to their perhaps not being believed. Symptoms similar to depression, such as being unable to enjoy things, often using drugs, alcohol, or possibly self-harm to try and control their emotions, which can lead them to having other diagnoses made or the PTSD being missed. Dissociating, cutting off from what's going around them, again, does lead to them being misdiagnosed. Often will have physical symptoms or somatic symptoms caused by distress, find that they can't put their emotions into words, and they'll come out, for example, as back pain, headache, all sorts of vague physical symptoms. Sometimes they will, in fact, often experience suicidal thoughts, and that may be how they come to the attention of services. And they may be impulsive and take risks. I won't go a lot into the management of PTSD as I'm running out of time, but I think it's just important in this group to keep in mind that actually the longest period of management for them may be just stabilization. Doing focused therapies and reintegrating into a new life in the UK is extremely difficult. And PTSD is extremely difficult to treat until such time as you have learned some of the language, developed some social connections, found accommodation that you don't think is going to be taken away from you any minute, had a decision from the Home Office, and generally just settled. And that can take many years and be frustrating both for the person and the people trying to treat them. So lastly, I'm just coming on to some of the support that there is for people seeking asylum. The Family Refugee Support Project is a very interesting one. It's a horticultural therapy based on the issue, as I've just mentioned, of people finding it very difficult to go straight into therapy, very difficult to talk about their experiences. And this is a family project where people are given a plot of land to use to grow things, along with support workers who talk to them and allow them maybe to talk about other things, perhaps to begin to touch upon some of their traumas, but without being forced into a one-to-one therapy situation, which they would find overwhelming. I mentioned before Refugee Women Connect. There's PSS Spinning World, which is a counselling project for children. Solar Arts is an art therapy project. Asylum Link has all sorts of things, destitution support, social work input, language lessons, social work caseworkers. Sahir House, I mentioned, the Sahir House is for people who are refugees and, well, for people living with HIV, but also takes people who are refugees and asylum seekers who are living with HIV and find themselves doubly affected by both of those issues. The Red Cross has a tracing service for people trying to find their relatives. And we have Liverpool Community Development Service, which is about including people in their social, their community, the wider community. Merseyside Refugee Support Network provides advocacy and welfare support, helping people with employment benefits and so forth. I'll just move on to, there are various guides. This is one which is done by Mersey Care, the links to that there that talks about some of the things I've discussed today. Various directories, which I won't go through there, but there are lots of different directories online with various sector support. The Helen Bamber Foundation works with survivors of human cruelty and human trafficking. And the City Hearts Project works with victims of modern slavery. There's also a very useful World Health Organization migrant health guide, which includes a country-specific A to Z, where you can look up the country the person's from, find a short outline of what life is like in that country, what the major political issues might be, what the major health issues might be, so that you can find out, for example, whether a particular diagnosis that you think a patient might have is common in that country, a disease, an infectious disease, for example. It gives a lot of information, quite helpful when trying to diagnose people whose background you may not really understand very well. And lastly, this is an excellent online resource hub put together by Philomen Owamalaya, who basically brought together all of those resources into one online hub where you can go and get up-to-date information about the rights and well-being of people seeking asylum and to help you work with them effectively. And that is it. I have some case studies, but I think we'll leave those as I'm running out of time. But thank you all very much for listening, and I will hand back over to Will.
Helen, thank you very much. That was really, really interesting. You've taken us through a lot there. You started off with your own experiences and your own kind of personal history of experiencing what people's views are in this country to people from abroad and racism. And then it was really useful to hear you explain about the process that people go through in seeking asylum, because that's certainly something that I don't know the details of very well. And then going on to talk about mental health as well. So really, really interesting. If anyone has any questions or anything they want to clarify, feel free to write in the chat box. We've got a couple of minutes before we hand over to Maureen at 7:30. I wanted to ask you, you may not know this because this maybe not specifically in your expertise, but I'm just wondering on what basis they make these decisions about approving applications, and how do they get to the point of getting refugee status?
Yeah, it's difficult to say actually, because the Home Office, I suppose, like the NHS, really is quite an impregnable system. They do make an effort, I think, to try and work with people. There are Home Office caseworkers, and the ones I've spoken to have generally been helpful people who want to try and help people to navigate their way through. But the system is stacked against people receiving an asylum, refugee status. So mainly we find out through, for example, migrant help, ways to get a solicitor, and the solicitors guide them through the process, which of course costs money. And often I think what healthcare professionals can do to help is, if they're able and have the resources to provide information in support of their application, or at least it doesn't necessarily you don't need to state a view one way or the other, but to provide information that may be relevant. So to document, for example, evidence of torture, if they've been examined and that's been found, to document the evidence that you see that they have post-traumatic stress disorder. And even if you don't have the time or resource to do a full report, even to provide a few paragraphs that the person can pass to the Home Office as part of their application, it can help them to build a coherent case. Often the person themselves, as I've said, just finds it so difficult to talk about what's happened to them, and it's very easy for them to be disbelieved. I think in all the time I've worked, sort of 8 or 10 years in that area, I think we came across as a team one person who we think wasn't telling the truth, and they eventually were arrested for fraud and imprisoned about something else. It was a monetary fraud. But everybody else, even the ones that we initially thought this is a strange story, want to find out a bit more about this, they were all completely genuine. Unfortunately, not all of them got leave to remain, but those that did, I think, were helped by having good medical records supplied to them for the use of the Home Office. And even if that's a copy letter from their clinic, I think that helps them to make a really positive, a really good case. But as I say, the rates of being granted status are pretty low.
Yeah, and that's something that isn't really talked about that much, really. It's certainly not in the way that it's presented in a lot of the media. That's really interesting. If anyone else has any other questions, do let me know. I was going to ask you as well just about the level of care and how that kind of works. So I think you talked a lot about the moving around, so different accommodation, different places, especially initially. Is it possible to get continuity of care, and kind of separate to that, or kind of related to that as well? And do you see people do get better, and do you see other real outcomes and changes that you see?
Yeah, I think that people do move around a lot, and it's very difficult. There's been various attempts to give people handheld records that they can take with them, which I think have been not necessarily always successful. Giving people a copy of their letter after they've been seen, I think, is really helpful for them, and telling them what it is as well, because if it's not in their language, they may not recognise it as being important. But yes, people do move around, and unfortunately that does mean that quite often I haven't been able to see the outcome of people who've been treated. It's because they've come to Liverpool, then been moved to Manchester, and next thing I know they're in Glasgow, or well, I don't know, but later find out. But yes, I have seen people getting quite a lot better, but I would say the timescale has generally been about 5 years. It has been the time it takes them to get their home office decision, to get some accommodation that is permanent, to make contact with their family in their country of origin, which is hugely holds people's mental health back if they can't get in contact with their relatives to find out if they're okay. And I think, and then I've seen a few people then go on to get jobs and find a partner, have children, have families in this country. But I think thinking that people are going to get better within 6 months, a year, I've just found that increasingly unrealistic. It's a very long process to recover. And I think even then, most of the people I've seen aren't fully recovered. They have a new life and a different life, but they are still, still very scarred, obviously, by what's happened.
I guess the main thing is just providing the support to get through that. We've got one question here, which I'll just ask you quickly, and then we can have a couple of minutes just in between. So Madeline Jacobs has asked, you mentioned earlier that refugees who get granted leave to remain in the UK have their case reviewed every 5 years. Is it more common or less common for refugees to be allowed to stay after this review?
Usually if they've been given leave to remain for 5 years, they usually get leave to remain indefinitely, which is one of the lovely things. So when they do get leave to remain for 5 years, you can usually encourage them that, yes, they are now safe to try and put down some roots here. I haven't seen anybody sent back after their 5-year leave.
That uncertainty must be really difficult though, I guess. Thank you.
Yeah, and I often find that people expect them to be overjoyed with leaving that 5-year leave to remain. But of course, after everything that's happened, it's very difficult to be overjoyed because they're worried about what will happen next. I need to get a job. I need to get some money. I need to get my benefits. I used to be a university lecturer. How am I going to do that in this country? Will my qualifications be fit for purpose here? And everything else that goes with starting again.
Brilliant, Helen. Thank you very much. It's been really fascinating.